guys, pardon the messy look I got going on here. I just got out of 10 hours of work. I am exhausted, but we are going to get through chapter 21. It's super short and sweet. Talks about musculoskeletal and anti-inflammatory drugs. So basically skeletal muscle relaxants and NSAIDs most likely, once we get to that point. So some disorders of the musculoskeletal system can be attributed to structural defects that may require surgical intervention rather than medication. However, many disorders associated with pain, spasm, abnormal contraction, or impaired mobility do respond to medications classified as skeletal muscle relaxants. So sometimes surgery is an option for treatment. Other times it does require long-term chronic treatment with medication, or if it's an acute problem, acute treatment. So, other options for treatment: rest, physical therapy, mild analgesics. Muscle relaxants are usually given on a short-term basis, and after the acute pain subsides, exercises take the place of medication and muscle relaxants are discontinued. Most of them affect the central nervous system with no direct effect actually on the skeletal muscle itself. Basically just tells the muscle to relax. And a lot of people who have pain, their muscles are tight and contracted, and that's what's causing all that pain. So the resulting action of these medications reduces muscle spasms, causes alteration in the perception of pain, and produces a sedative-like effect promoting rest and relaxation of the affected part. Chapter 20, we discuss benzodiazepines. They're mostly used for anxiety and seizures. However, they also can be used for muscle relaxants. Really try to stray away from that though, because they are an addicting substance, and we want to avoid it if we can, if we have better options. Another centrally acting muscle relaxant is methocarbamol. And a different type of muscle relaxant, dantrolene, causes a direct effect on skeletal muscles and is used in the management of spasticity resulting from upper motor neuron disorders such as multiple sclerosis or cerebral palsy. Now keep in mind, cerebral palsy and multiple sclerosis are two disease processes that are completely different than muscle pain related to injury or to strain. MS and ALS and cerebral palsy are constant, chronic, lifelong problems where people are dealing with severe contraction of muscles. So dantrolene causes a direct effect on those muscles. Those patients might also be on long-term chronic muscle relaxants, but dantrolene is usually only used in those cases of those chronic, lifelong diseases. Side effects of muscle relaxants can include drowsiness, dizziness, dry mouth, weakness, tremor, ataxia and seizures, confusion and nervousness, slurred speech, blurred vision, hypotension. This list is long, isn't it? Which makes you think that somebody who's using these medications wouldn't want to be on these for very long, because these side effects are pretty interrupting. They're definitely an interruption to life. Precautions occur: pregnancy, lactation, hypersensitivity, history of drug abuse, especially with our benzodiazepines, liver and kidney dysfunction, COPD, cardiac disorders, etc. Neuromuscular blocking agents. We discussed these in one of our forums a couple weeks ago. This is a class of drugs that should scare the absolute living crap out of you. You see a neuromuscular blocking agent and you are thinking to yourself, right patient, right dose, right everything. You need to be completely in the right with this medication. The reason being, and a lot of you touched on this, is the minute you administer a neuromuscular blocking agent, it's IV. You can't take it back. There is no reversal agent. You have paralyzed this patient. So if you don't have a good airway, if you don't have a tube in or some sort of way to ventilate this patient, you have just put them into respiratory arrest. In addition, while they're going downhill, while they can't breathe because they're paralyzed, they are wide awake and aware of everything. They just can't move and they can't tell you. So let's say you gave someone this and you left the room. That patient now suffers because they can't breathe, they can't have oxygen, and they also can't yell out for help. Now let's say you're in the room. Again, you better be ready to get that airway in ASAP. So neuromuscular blocking agents are administered and ordered by anesthesiologists or specially trained personnel skilled in intubation, medically induced paralysis, and cardiopulmonary resuscitation. Table 21.1 has a great little chart of all the muscle relaxants. Dantrolene, again, is that special one for MS and cerebral palsy, not for trauma or rheumatic disorders. All the others can be used for multiple problems. Baclofen, carisoprodol, cyclobenzaprine, methocarbamol, and tizanidine are all commonly used for muscle spasms. Anti-inflammatory drugs are used to treat disorders in which the musculoskeletal system is not functioning properly due to inflammation. Arthritis, bursitis, spondylitis, gout, and muscle strain can cause swelling, redness, heat, pain, and limited muscle and joint mobility. Analgesics and corticosteroids are used at times for the acute stages. Those were discussed in other chapters. NSAIDs such as ibuprofen inhibit the synthesis of prostaglandins, which are a part of that inflammatory process. So they cut down on the amount of inflammation. Ibuprofen has a ton of uses, whether it's headache, pain, sprain, menstrual cramps. It's just a great sort of catch-all for inflammation and pain. A lot of times it's also used in those rheumatic disorders such as rheumatoid arthritis as a first line to help treat pain. Let's see. It goes through a little bit of a discussion. There are other NSAIDs such as diclofenac and where was the other one I saw on here that I wanted to talk about? Let's start with diclofenac or any of the NSAIDs. The one I'm thinking about is completely slipping my mind. Diclofenac and NSAIDs like ibuprofen and naproxen, indomethacin, that was the other one, and ketorolac, are all, because they inhibit prostaglandins. Prostaglandins are also produced in the stomach to protect the stomach lining. Any of these medications can cause GI bleeds. So if a patient is taking them, we want to be careful that we're monitoring them for all signs of GI bleeding, whether it's blood in their blood that they're coughing up, blood in their stool, etc., because they all can have that side effect. Ketorolac actually is one of those medications that is limited to 5 consecutive days of use and no more. It is especially offensive when it comes to kidney and renal dysfunction as well as GI problems. COX-2 inhibitors. These are a little bit more selective. They are selective for the COX-2 receptor. It has anti-inflammatory, analgesic, and antipyretic activities. It does not inhibit COX-1 and therefore does not inhibit platelet aggregation or inhibit the production of mucosal productive prostaglandins, so it is better for the GI system. It doesn't have the same bleeding risks. However, it does still have cardiovascular risks that come along with NSAIDs. And there's a little bit more in this section on that. So, side effects of the NSAIDs frequently include GI ulceration, epigastric pain, nausea, and heartburn, MI, thromboembolism, stroke, hypertension, and heart failure. That line right there should tell you that below you're going to see a precaution for cardiovascular disease. Fluid retention, peripheral edema, headache, which is kind of funny. I think every medication out there can cause headache just because people complain of it pretty frequently. So when they're doing the testing for these meds, headache is a common complaint and thus gets put into every side effect. So keep in mind the biggest precaution is history of a GI bleed or ulcer, kidney dysfunction, cardiovascular disorders. Those should be no-nos for patients taking NSAIDs. Older adults are especially sensitive to the side effects, so we also want to be careful with those patients. Okay. Osteoporosis therapy, and again, table 21-2 has a great little chart of all the NSAIDs and COX-2 inhibitors out there. Osteoporosis therapy. Osteoporosis is defined as low bone mass and deterioration of the bone tissue, leading to bone fragility and increased susceptibility to fracture. You see this especially in older women. As we get older, ladies, we stop making estrogen, and estrogen is a part of the bone modeling process. So as estrogen decreases, our bones get thinner and thinner, and thus we're more likely to break a hip or have, when you see little old ladies hunched over, usually it's because their vertebrae have started to crumble, and those are tiny, minuscule, multiple fractures that cause their spine to go from this to that. Wrist is also common, but really hip and spine is what you see the most. People are diagnosed based on their bone mineral density. The further away from zero into the negative that it goes, the worse it is. Therapy mainstays are calcium and vitamin D supplementation, and we start that even in women, hopefully, who are younger, and if you are a woman, you should be taking calcium and vitamin D as well. We talked a little bit about estrogen. You can replace estrogen. They use hormone replacement therapy for postmenopausal osteoporosis prevention when the patients are unable to take other agents that we're about to discuss, because estrogen replacement therapy is a little dangerous due to the fact that it can prevent, or it can cause cancer in the long run. So let's talk about selective estrogen receptor modifiers. Raloxifene is the one in this class that stands out the most. It has estrogen agonist activity on bones and lipids, as well as breast and uterine tissue, so less likely to cause breast and uterine cancer. The incidence, blah, 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 usually taken once a day, obviously contraindicated in pregnancy and women with a history of thromboembolic disorders because it can increase your risk for a clot. Calcitonin salmon. A synthetic form of the hormone calcitonin is available as a nasal spray or a subcutaneous injection used in postmenopausal osteoporosis in women who are more than 5 years past menopause. Calcitonin is involved with calcium regulation, and calcium is involved in bones. So, therefore, it increases spinal bone density and can help with a little bit of acute pain in spinal fractures. Calcitonin is usually used in women who cannot tolerate hormone replacement therapy or in patients who hormone replacement therapy is contraindicated. Parathyroid hormone, teriparatide, is an injectable form of parathyroid hormone. The parathyroid is also involved in calcium regulation and thus bone mineral density. It increases GI calcium absorption, which is super awesome, and renal tubular reabsorption of calcium, meaning the body gets to hold on to more calcium, and so do the bones. Bisphosphonates, this is the widest category used for osteoporosis treatment. Usually this is first line before anything else. Teriparatide, before we go too much further, can be used for 2 years, and that's it. So really short-term treatment on that, because think about it, if a woman has menopause somewhere in her 50s and she lives to be 70, 80, there's 20, 30 years there where she may or may not need treatment for low bone mineral density. Bisphosphonates are non-hormonal, which is good. They act directly to inhibit bone resorption and thereby increasing bone mineral density at the spine and hip, as well as decreasing the incidence of first and future fractures. That's a weird statement. So if a patient's already had a fracture, bisphosphonates can help cut down on the likelihood that they'll have another fracture. Alendronate, risedronate, ibandronate, they all sound the same, and they are all included in this class. They need to be taken first thing in the morning if they are taken orally with a glass of water and nothing else, and the patient has to remain upright because the drug is extremely irritating to the esophagus and the stomach lining. So side effects, of course, GI distress, abdominal and chest pain, etc. The great thing about bisphosphonates is that they last, so when you start taking them and you've been taking them chronically, they tend to have a lasting effect. So even if you forget a dose or skip a couple doses, that effect that they have on the bone goes on for quite a while. So that covers musculoskeletal and anti-inflammatory drugs. Again, short, sweet little chapter, which makes me super excited. I'll be recording the next one probably either on my break tomorrow at work or again after work, so look forward to this tired, exhausting, rushed sound. Hope you guys are all doing well. Email me with any questions. Thanks.